Okay, so it should be recording. You can see the slides okay? All right, wonderful. Well, thank you so much for being here. So just some quick Zoom guidelines. So everybody's going to be muted during the presentation. Let's see. Oh, great. Okay, I'm trying to let you take care of that. Oh, I think you already went through these, Brandy, the guidelines, so maybe we can skip through this. But yeah, please feel free if I don't get to your questions today, feel free to reach out and email me, and I'll do my best to kind of answer them, or direct you to somebody who may be able to answer them. All right, so we're going to be talking about kind of supporting mental health in people with mosaic Down syndrome, and talk a little bit about at the end about the regression research study that we are kind of sort of in the middle. We're getting ready for the next phase, and we're about to open up a larger survey, so I'm excited to talk about that too. So just a little bit about me. I think I've met quite a few people that are here, but for those of you who don't know me, I'm a clinical psychologist. I have been working with the IMDSA since like 2013, I think. was the first one. So it's been a while. It's been just a wonderful organization and wonderful experience working with Brandy and the other IMDSA people. So I just have really enjoyed that. I'm a clinical psychologist, and I'm really interested in kind of how we measure mental health symptoms, and how we can use that to improve mental health services, especially for people who are often kind of left out of those services, including people with Down syndrome, and mosaic Down syndrome as well. So just to kind of start off, with kind of what we know about mental health, among people with Down syndrome. So a lot of the studies out there show that people with Down syndrome do tend to be at a higher risk for a lot of mental health conditions. And that's counter to the idea that like people with Down syndrome are always happy, that kind of public persona, that kind of public stereotype of people with Down syndrome. What in fact that we see is that people with Down syndrome experience really high rates of Alzheimer's disease. It's actually one of the reasons why we kind of know the genetic causes of Alzheimer's disease is because people with Down syndrome experienced such high rates of it that directed people to the 21st chromosome and finding that like one of the genes that influences risk for Alzheimer's is on the 21st chromosome. However, what's I think kind of less appreciated and less understood is the higher rates of anxiety and depression, and in particular depression with psychosis, as well as acute regression. This is starting to get a lot more kind of notice and a lot more discussion, and so hopefully that will then lead to improved prevention and treatment efforts, but we're still kind of behind the ball on that. So I'm going to talk a little bit about kind of what these like mental health diagnoses mean, what they look like, how they might look a little bit different in a person with Down syndrome. And so for people with mosaic Down syndrome, they'll get kind of move a little bit later once we have an understanding of what these diagnoses are and what they look like. We'll talk a little bit about how that might be different in people with mosaic Down syndrome. So this first part's going to really be focusing more so on just kind of Down syndrome broadly, which which may include people with mosaic Down syndrome. We know that mosaic Down syndrome is a spectrum, basically, and there are ways in which people with mosaic Down syndrome are more similar to people with Down syndrome, and other ways in which maybe they're more similar to people with neurotypical development. And so we'll talk a little bit more about the results of the LEAF study and what we've learned there and what we're continuing to learn, and hopefully we'll do more research and learn more. But so just a basic overview of what these things are. I'm going to start with anxiety because this is the one that is the most common, that we see anxiety the most. And that's generally true in the general population too. Like of the mental health kind of disorders or mental health concerns that are out there, anxiety is the most common. And so we see that in Down syndrome as well. So when we talk about anxiety, that includes things like separation anxiety. That's being afraid of being away from, a caregiver or a loved one, either because of fear befalling them or that they're worried that something is going to happen to their loved one. Social anxiety is fear of social situations and social interactions. Generalized anxiety is kind of a just everyday worries about everyday things. Panic attacks are anxiety about having, or panic disorder is uh, fear about having panic attacks. That's a sudden, just out of the blue, kind of, panic like symptoms, obsessions and compulsions, are having kind of routines and rituals that are meant to kind of neutralize obsessive kinds of fearful thoughts. And then finally, post-traumatic stress is is the result of experiencing a traumatic event. Okay, so specific phobia. This is an intense fear of a specific object or situations. What we've seen, amongst people with mosaic Down syndrome and Down syndrome, a lot of like fear of animals, fear of dogs, fear of the dark, a lot of anxiety about storms, and I think some of that may be due to some of the kind of sensory, the kind of lightning and things like that. It could be kind of, overwhelming, kind of from a sensory perspective, but just also kind of fear of, of what might happen. Maybe some fear of doctors, blood draws, things like that. So some things may be, fear about things that they might only encounter every once in a while, like going to the doctor and getting a blood draw, but that can have a significant impact on them, versus, fears that may be present kind of every day. And the fears is kind of out of proportion to the actual danger. So in people with, with Down syndrome, if they have a harder time communicating what they're afraid of, it can be really confusing for caregivers to identify, what it is that they're afraid of. It may just look like avoiding certain places, people, or activities. They may have kind of tantrums or just shutdowns. And so, where it's like they encounter the thing that they're afraid of, then they just like kind of shut down, stop and drop, refuse to kind of engage in that situation. And again, they may have difficulty kind of explaining what it is that they're afraid of, but they just kind of react because they just are overwhelmed with intense emotion in the moment. Social phobia, or we also call that social anxiety disorder. The core of this is an intense fear of being judged or embarrassed in social situations. For some people, they do fine with like one-on-one friendships, or in like, kind of small groups of comfortable people, but when they're in groups of unfamiliar people, they may shut down, or get anxious, or maybe they're fine, in kind of day-to-day social situations, but they're afraid of performances. And so then they get like stage fright. So we can have generalized social anxiety where they're basically afraid of all kinds of, social situations, or they can have specific social anxiety where it's really only popping up in certain kinds of situations. So for people with Down syndrome, it might look like refusing to participate in group activities or school events, being kind of clingy, to familiar adults, like in a, at an event or something. They may just stay by their parents' side. They may avoid talking to their peers. They may have difficulty making eye contact when otherwise that's not an issue for them, or again, kind of shutting down in social situations. I want to talk a little bit about selective mutism. That was one of the questions that somebody had, and a question that I get a lot. People ask me about selective mutism. We do see this in Down syndrome, and I do, there haven't been studies specific to this, but just based on the number of times parents ask me about this in particular, I suspect that it's more common than it is in people with Down syndrome than it is in the neurotypical population. Selective mutism is sometimes considered like an extreme form of social anxiety, where there's a consistent kind of inability to speak in specific social situations despite speaking in other situations. So if a person is not speaking at all, if they're just suddenly just not speaking, or they're whispering in all situations, that would not be selective mutism. And in fact, that might be kind of concerning for other kind of neurological conditions, or, or regression. But if it's a sort of situation, what we see often is that they speak at home, they're their usual pleasant, social, bubbly self at home, but when they're at school, they don't say a word. And the teachers might, and like they might comment, like, they're not talking in class, like they're not talking to their peers, they're not talking to anybody, or they go to work and they don't talk. So it's a specific situation where they're not talking, but they're fine in other situations. And so many often You know, most often people will describe, you know, that they are experiencing that fear of evaluation. But for people with Down syndrome, it may be a little bit harder for them to really understand and express that. And sometimes they just feel like the words won't come out. Like they want to talk, but they just can't get the words out. You know, like that their brain has kind of just put the brakes on. Let's see. So sometimes this can be misinterpreted as like stubbornness rather than anxiety. I think it's important to recognize that anxiety is kind of often, you know, most often kind of underlying this with their refusing to talk in certain situations. All right, generalized anxiety. Again, this is kind of just excessive worry about many things. So they worry about school, they worry about health, they worry about their family members, they worry about the weather, they worry about what they're going to do that day, you know, where it's just a lot of worry, a lot of questions. And you can see that as just like asking repetitive questions about what the plan is for today. And if the schedule changes, maybe they're, you know, you can tell they're visibly, you know, anxious and asking about that, or they're worried about safety. They may need a lot of reassurance, you know, and kind of asking for a lot of reassurance seeking. Physical symptoms are really common, you know, in people with generalized anxiety disorders. They might report stomach aches or headaches. In the general population, muscle tension is really common with generalized anxiety disorder. But I see this much less in people with Down syndrome, I think because they often have low muscle tone. And so we don't see that, you know, kind of hallmark symptom of muscle tension, you know, in people with Down syndrome. But irritability and restlessness, I think, are more common, or more kind of hallmarks of that, where they just be that might. And you can kind of imagine, like, if you're worried about something at work, or you're anxious about, anxious about something, like oftentimes that makes us more irritable. We're a little bit more snappy, or a little more irritable, and so that's true for people with Down syndrome too. Obsessive compulsive disorder, and this is often described amongst people with Down syndrome as being something that's especially common. So the way that we think about OCD, from a psychological perspective, is that a person experiences kind of unwanted and repetitive thoughts. Oftentimes it's about something that they're contaminated, that they're dirty, that they've done something they're not supposed to, that they're going to hurt somebody. They get these kind of these really upsetting and distressing obsessive thoughts that they can't get rid of. Sometimes it's a song stuck in their head. Sometimes it's, there's a wide variety of things that can cause these obsessions, but the obsessions are unwanted. And they engage in these kind of repetitive compulsive behaviors in order to try to reduce the obsessive thoughts. So these things are like really tightly linked together. And sometimes they make sense, in a way. So a person might have obsessive thoughts about being contaminated or being dirty. And so then they feel like they have to wash and scrub things excessively. So those things are kind of related. Sometimes they have compulsions that are not at all related. It might be counting the ceiling tiles, or counting anything that they can see. It might be that they have to come through and kind of close everything, or check locks or things like that, and they're not necessarily connected to whatever the obsessive thought is. And so that can be confusing to people. But what has happened is that person has found that when they engage in that ritual, it makes the obsessive thoughts like reduce or go away, and so that kind of keeps it going. And then for us to kind of consider that something is, an obsessive compulsive disorder, it has to be time consuming and distressing. And so usually we have a kind of a cutoff that if it's, occurs for more than an hour a day, the obsessions and or the compulsions, and it's causing significant distress or problems in their daily life. In Down syndrome, it can be hard because it may be harder for them to express those obsessive thoughts, that we may observe that they're engaging in compulsive behaviors, but it may be hard to distinguish if those are associated with some sort of obsessive thought process, or if they're just doing something, if they have autism and they may have repetitive behaviors associated with autism, like that's not necessarily the same thing, because for people with autism, those repetitive behaviors are often comforting. It's something that they use to self-soothe, or to feel regulated, versus for people who have OCD, they don't like doing the compulsions. The compulsions are upsetting to them and they wish they could stop. But they, but they can't, because they feel like if they don't do them, they're going to be overwhelmed by their anxiety. And so that can be hard. That can just be hard to diagnose, for a psychologist or a psychiatrist to be able to diagnose that, because that might be hard for them to explain that, to describe that process, and we have to go based on what we can observe sometimes. Some other manifestations that we might see is something called obsessional slowness, and this is where a person has to do everything just right, and so it may take them an hour to brush their teeth because they feel like they have to pick up the toothbrush in just the right way, and if they pick it up the wrong way, they have to set it down and they have to try again, and they have to feel like they have to get the like curly cue on the toothpaste just right. It's like there's like this need to have things done just right, and so they can take a very, very long time to get things done. We want to make sure, again, that we're distinguishing between something that is just their routine. People with Down syndrome tend to love routines and that can help support them, having a consistent thing that they do. I come home from work at this time, I eat dinner at this time, I go to bed at this time. Like those could be helpful and supportive, but sometimes they become so rigid that then they get upset if it's like 5 minutes after that time, then they're upset. Like that becomes then, kind of problematic. And so sometimes it's a really gray area, like where does something become problematic. All right, and then finally we have kind of trauma and PTSD. And so what we know, and again, we don't have a ton of data on Down syndrome with this, but people with kind of intellectual and developmental disabilities experience higher rates of stress and trauma. And the research suggests that for people who have developmental differences, that their likelihood of developing post-traumatic stress disorder or other concerns may be associated with their cognitive abilities. So they may be more vulnerable to experiencing PTSD if they have kind of lower levels of cognitive abilities, cognitive functioning. It used to be, there's a lot of myths that still persist out there. People used to think that like, oh, if a person has an intellectual disability, they're kind of protected from what's happened. They don't really know what's kind of going on around them, that they're somehow protected. They're more childlike, they're more innocent, they're more kind of whatever, and that led to these myths that they kind of weren't affected by by abuse or loss or all these other things. And I think people who work in this field know that's not true, but some of those myths still persist, I think, in the general population and amongst some medical professionals. Some behavioral expressions of trauma that we might see are things like increased aggression and outbursts, or self-injurious behaviors that have started after something stressful has happened. So maybe, and that can be a lot of things, and it could be things that are stressful to them that we might not think about, that may not be stressful for us, or maybe traumatic for them, and we experience it as just stress. And so that's something that we have to take into consideration too. It can also look like avoidance and re-experiencing, through flashbacks, or having nightmares. So if they're having an increase in nightmares after a stressful event, for some people, and I think this is another thing to keep in mind, if this is something that's happened to your loved one, if you know that something has, upsetting or stressful has happened to them, and you're seeing some of these behavior patterns, that doctors don't always, kind of recognize it, and they may be likely to diagnose some of these symptoms as being psychosis, kind of hallucinations and things like that, when they're more kind of stress related dissociations, where they feel like they're disoriented, or having flashbacks, but they're not able to communicate that. And then we also see, just I think with all of these things, this issue of diagnostic overshadowing, and that's where kind of doctors or teachers or caregivers just assume, they just say like, oh, that's just Down syndrome, like a person is having an actual medical or mental health crisis, or needs support, and they say, oh, well, that's just part of the disability, this just happens to people with Down syndrome. You know, and I hear this quite a bit. And so that's something that's called, as a name, it's called diagnostic overshadowing, where we're, you know, that diagnosis of the developmental disability or the developmental difference, genetic difference, is what kind of takes the blame for things, rather than recognizing, oh, this is a treatable mental health condition. And then finally, we have Down syndrome regression disorder, and or catatonia. And I put these things together because we are still, as a field, trying to figure out what even is Down syndrome regression disorder. Is it different from catatonia? Are they, you know, are they similar? You know, is it that catatonia is a feature of Down syndrome regression disorder? Is it just the same? So we're doing research now to try to figure this out. And there's a lot of people kind of across the country that are working on this. But Down syndrome regression, it's the essence of it is that it's a sudden, or we call subacute, which just means, you know, over the course of, you know, of weeks or months, a person suddenly loses kind of previously acquired skills or abilities. And so, you know, they may lose, you know, the ability to, you know, to talk. They may suddenly start whispering. They may lose the ability to, you know, kind of walk and climb, go up and down the stairs, to dress themselves independently, to use the bathroom independently. You know, so things, so there is just a sudden change. And when we talk to families who've experienced this, they describe just like an almost over the night, they are a different person. So not necessarily like the kind of summer drift that you might see, you know, your kids kind of, you know, are off out of school for the summer and maybe they're not reading quite as well by the end of the summer, but then they go back to school and they kind of pick back up. Like, it's not that kind of regression. It's like a sudden drop off. Catatonia is another syndrome that's characterized by kind of motor or behavioral changes. And what that means is that the kind of classic presentation of being catatonic is just becoming unresponsive to your environment. But there are a lot of other, you know, kind of symptoms of catatonia. Can be engaging in sudden, you know, sudden stereotypic movements. You know, so maybe the person, you know, didn't engage in didn't have stereotypies before, but suddenly start doing things like rocking or hand flapping or, you know, wiggling their, you know, their fingers. Sometimes it's described like that almost looks like a sudden autism onset, you know, whereas, you know, if it's autism, we see that onset is in the early childhood years, you know, usually before age 5 that we see those symptoms. You know, autism doesn't start suddenly when a person is, you know, 14 years old, 20 years old, you know, but it can look a lot like that. And so it's important to recognize that these symptoms can be caused by a lot of different things, that there are a lot of kind of medical, neurological conditions that can cause this presentation. So the most important thing to do is to get a thorough medical evaluation, you know, before, you know, just giving it a label of Down syndrome regression disorder, because it could be, there are cases where it's, you know, kind of untreated celiac disease, or, you know, their thyroid, you know, values have gotten so far out of whack that it's kind of caused these sorts of things. So good medical evaluation is really important. Okay, so now what about mosaic Down syndrome? How does that kind of fit into all of this? So we know that people with Down syndrome kind of at higher risk for these disorders. How are people with mosaic Down syndrome affected? Like, what do we know about that? You know, and parents, you know, kind of want to know, because they want to know, like, should they pay attention to the research on Down syndrome? Is that going to apply to their child? You know, if their child is having some sort of a, you know, kind of mental health concern, you know, they want to know, is this because of the mosaic Down syndrome, or is it because of something else? And are there services that are out there that can help them? So these are kind of important questions for understanding, like, you know, how is mosaic Down syndrome similar or dissimilar from, you know, from Down syndrome as a whole? And so this is the study. And so I presented on this at the research retreat just this last year, but I'll touch on it again in case you weren't there. So we did the LEAF study. This was, gosh, I mean, I think we started collecting pilot data back in 2013. We collected pilot data for several years, and we were able to use that to get NIH funds. We launched the study in, I think got it in 2017, probably launched in 2018, and started collecting data for several years from from the first part of the study was from people with mosaic Down syndrome exclusively, and then the second part of the study we we opened it up to people with with just regular trisomy 21. So we had 62 participants with mosaic Down syndrome, 53 with regular Down syndrome. They were recruited through IMDSA and these other great Down syndrome associations. These were people who were aged 12 to 45. And I think it's interesting to know that 13% of them, so just coming into the study before we did any mental health evaluations, 13% reported that they had a previous diagnosis of depression, and 26% reported that they had a previous diagnosis of anxiety disorder. So just kind of coming into the study, that was what they reported. The goals of the study were, we wanted to know if screening instruments were valid for use in people with Down syndrome. We wanted to know what the kind of prevalence of depression and anxiety were amongst the sample, and in particular, if there were differences between people with mosaic Down syndrome compared to Down syndrome. That might help us to understand, like, is it a kind of a dose of the 21st chromosome that influences that, and so if we think, well, this is the result of, having an extra chromosome 21, we would expect to see that people with Down syndrome have higher rates of these things than people with mosaic Down syndrome. If it's due to something else, we might get a different pattern. And then we also want to know what role do stressful life experiences play in mental health for people with Down syndrome. Okay, so so we asked people to complete what we call a clinical diagnostic interview. And this is where we kind of sit down and we go through symptom by symptom, through these kind of major classes of psychological disorders, to identify whether or not a person, kind of meets criteria for these. And so here you can see in the, let's see, there they are. Okay. The things that had little stars were the things that were kind of statistically significant. And that we can kind of more confidently say, like, yes, people with mosaic Down syndrome reported experiencing more depression, more agoraphobia. Agoraphobia is kind of in there with panic disorder, where a person is afraid to go places because they might have a panic attack. And so we see kind of more agoraphobia and more social anxiety. And so we do see the others were, were not significantly different from each other, but also still very prevalent. So if you see like this, the overall sample of people with, anxiety disorders was quite high. And so a lot of people had anxiety, a lot of people had depression. This is more than what we would expect in the general population. If we were to just say, like, this is a random sample from the general population, how many people would have depression? We would expect it to be about, about maybe 7%. This is significantly higher. We also use something called the NIH Toolbox, which asks about kind of emotions. And here, this is what we call a norm referenced measure. And so the way that this works is this line here, 50, is what's considered to be average. And so this is designed in such a way that we can kind of compare how a person scores relative to the population average. And this is just the general population. And so what we see here, so the blue are people who have trisomy 21, the red are the people who have mosaic Down syndrome. And so what we see here is that the loneliness was the thing that was significantly different. People with mosaic Down syndrome reported significantly more loneliness compared to people with regular Down syndrome. We also see, I'm not kind of here comparing statistically the difference from 50, whether they're significantly higher than 50, but we do see, some elevations in sadness, some elevation in fear for mosaic, and then a little bit of elevation in perceived stress, and then also lower positive affect. And so positive affect is like feeling happy, joyful, ask these kinds of questions. And I think it's notable here too, is that what we see is that people with Down syndrome and mosaic Down syndrome are reporting less positive affect than the general population, which again is like counter to that stereotype that people with Down syndrome are always happy. Like this suggests they're actually expressing less positive affect, less happiness than people with, in the general population. Okay, so I want to take a deeper dive on loneliness in particular. This was something that um, at the last IMDSA research retreat, several people like in the self-advocate meetings, and then just in other conversations, just one-on-one with folks, people were talking about feeling lonely and the relevance of that. And so I think it's interesting that that kind of popped up in the data, but then that was also part of the conversations people were having. And I think it's also really important to talk about because, we're kind of just seeing this in a lot of places, and it's popping up in a lot of other conversations too. So loneliness is really important, from a physical health perspective. The Surgeon General, I think it was in 2023, released a report on the epidemic of loneliness, and kind of talking about the physical and mental health toll that loneliness has on the population. So some studies suggest that 45% of people with intellectual disabilities experience chronic loneliness. And loneliness is associated with physical health, including heart disease, diabetes, obesity. It's associated with mental health, including anxiety and depression. Alzheimer's is associated with loneliness. It's affected, it's associated with just overall quality of life. It's, hard to feel good and feel like enjoying your life if you're experiencing chronic loneliness. But there are strategies that can help. And that's one of the things that I wanted to spend some time talking about, some of these strategies. What can we do to support a person if they're experiencing loneliness? It's also, I think, relevant because the World Down Syndrome Day this year, coming up in March, is their whole kind of focus of this year is on loneliness. And so that's coming up. Oh yeah, and here's a Surgeon General's report. If you're interested in it, it's kind of a long read, but it's interesting, and it has some useful information in there too about things that can be done to talk about loneliness, or to combat loneliness. Okay, so why is this important in Down syndrome? And just kind of understanding what it is. So loneliness is not just about not being around people. Loneliness is about a gap between the amount and the type of social relationships you want and what you actually have. And so there are people out there who are fine, who prefer to have just one or two friends. They don't need a lot of social contact. They're pretty happy on their own. And so, just because a person is alone a lot doesn't necessarily mean they're lonely. There's also people who are around people all day, and maybe they have a lot of people in their life, but they want more, or they want different kinds of friends. They want romantic relationships, and they only have platonic relationships, or they feel like they have surface level friends and they want like a deep friend. They don't feel like they have somebody that they can like really call and talk to if they're having a bad day, for example. And so loneliness is that gap. And so, again, we see that like people, the research in Down syndrome in general is that people have fewer friendships and just kind of a thinner social network. If you kind of think about each person and drawing lines to the people that they're connected to, like their map or their kind of social network, has less lines and connections. Some of that may be due to, to kind of communication challenges, and then just also limited community inclusion, that there are not enough inclusive spaces where, people with disabilities and without disabilities, can kind of, interact and feel welcomed together. We're still pretty siloed. And I think particularly for people with mosaic Down syndrome, I think this is really the crux of that matter, is that they don't fully fit in with people with Down syndrome. They don't fully fit in with their neurotypical peers. And I think it's hard for them to find that set, like their tribe, and the people who kind of get them, that they connect with. And I think that's a particular challenge. And then transition challenge, that school to adulthood transition is really hard, because when you're at school, you have kind of a built-in, and certainly people are still lonely at school and experience loneliness at school, but it's a little bit easier when you're at school to make friends. You have classmates and so there's kind of built-in supports there, and so it's a little bit easier to kind of find and make friends at school. But when you transition to adulthood, It's hard to make friends as an adult. You know, you kind of get in your life, you know, maybe you like the people you work with, maybe you don't, like, you know, but it can be really hard. And so that transition is really a big piece of it. um, but there are things that we can do to kind of help them. So what are the things that kind of increase this, you know, vulnerability? I want to talk a little bit more about that. So I mentioned the smaller social networks. So they have just kind of fewer, you know, friends and social connections. You know, some of that, you know, that gets compounded, I think, for people who live in kind of rural areas. But I talk to a lot of people who live in big cities that are really resourced, and they still have a hard time finding, you know, like meaningful, inclusive activities for their loved ones. You know, they may have fewer chances for community participation or employment. You know, I think there's a lot of talk, you know, within the Down syndrome, you know, kind of advocacy world about employment. You know, like IMDSA really pushes a lot for employment, you know, which is great. And, you know, employment's about more than just a paycheck. You know, it's also about, you know, meeting people, meeting friends. Most people meet their friends, their, you know, romantic partners at their jobs, you know, and so that, you know, that fulfills a need, you know, for that social connection and social opportunities as well. Um, the communication barriers, I think, are also significant. You know, that, you know, some of it has to do with difficulty with receptive and expressive language. So people with Down syndrome, you know, in addition to, you know, sometimes the kind of speech differences that come from just the way their mouths and their tongues are shaped, that can make it harder. Just, you know, the way that their brain processes information is different. And usually what we see is a pattern where their receptive language, so what they can understand other people saying, is better than their expressive language. And so oftentimes they can't express as much, you know, as what they understand. And that makes it hard because, for one thing, people tend to then underestimate what they understand. And so, you know, they may be more likely to kind of leave them out of conversations, or, you know, not get the benefit of the doubt. Or sometimes, you know, just, you know, I mean, the kind of worst case scenarios, people will just kind of talk about them in front of them, thinking that they aren't picking up on it. For people with mosaic Down syndrome, this study suggests that they on average have IQ points, you know, that are about 10 or 12 points higher than people with Down syndrome. But they still, compared to their neurotypical peers, often still experience some of these deficits. And what a lot of the self-advocates were, were saying to me in the interviews or just in discussions talking about socializing, is having difficulty kind of keeping up with the pace of a conversation, you know. And so they feel like the conversation has moved on by the time that they've kind of processed the conversation, what people are saying, and especially if it's a group conversation, you know, where like the conversation's kind of going back and people are jumping in. By the time they finally kind of have processed and formulated what they've wanted to say and they're ready to kind of jump in, the conversation has already like shifted and moved, you know, and so that they can very easily feel kind of overwhelmed and lost in those conversations. And then, you know, and then kind of other kind of co-occurring mental health conditions. So loneliness is really important because it can both cause, so loneliness can cause depression and anxiety, but also depression and anxiety can cause loneliness, because if a person has these pre-existing mental health conditions, that may lead them to be more withdrawn, or if they're socially anxious, that makes it harder for them to engage in conversations, and so they're more likely to experience loneliness. So it's a kind of a two-way street between those things. All right, so what are some things that that you can do to kind of support your loved one, you know, in terms of loneliness? So one thing is, you know, the biggest thing I think is kind of helping to create social opportunities. You know, so kind of getting involved, you know, activities like the Special Olympics, you know, the Best Buddies, you know, look to your kind of faith communities, recreation programs, you know, and I think having a mix, you know, of environments is helpful, of having, you know, activities that are just kind of open and inclusive, include people with disabilities and people without disabilities. I mean, that's really like the ideal, you know, is to have those. But depending on kind of where, you know, where they are, and like, you know, like who do they feel the most comfortable with, you know, and are there, you know, are there opportunities to do that? Find their hobbies, like what hobbies do they enjoy doing? Like, are there clubs around in the community. You know, look at your library for, you know, for activities and social clubs, and find things that they're interested in, and try to schedule those and have a kind of, you know, regular reoccurring events where they can go, you know, and meet people and make friends. You know, I think making connections with, you know, the, you know, Down syndrome associations, you know, the IMDSA, the SALT calls, I think are really helpful, for people to kind of get involved and connect with people who have similar experiences. And, you know, for people with mosaic Down syndrome, that's harder because they're not necessarily going to be in their neighborhood. But I think that's always been such an interesting thing, like going to the research retreats and seeing people connect and having that, you know, I think both the self advocates and also the parents, you know, being like, oh, like, you get it. You've been there. You get this experience. Social skills groups are really, you know, are really helpful. I would think, you know, I would suggest to maybe looking in, you know, even if they don't have, you know, a co-occurring diagnosis of autism, I think some of those social skills apply. You know, I think sometimes they've gotten kind of carved out into the, like, you know, these are autism specific things, but I think really that those are interventions and groups that help people that have a wide range of, you know, of kind of social skills needs. And so, you know, you might look into if there are, you know, like if you have an autism society or, you know, something kind of in your area that may run some social skills groups, if they're open to, you know, people with other neurodiversities, you know, besides just autism, you know, maybe an opportunity for them to develop maybe some of the social skills. You know, they may be kind of they may have some little gaps here and there that can be helpful. You know, online communities are really helpful. So, you know, so just try to find as many opportunities, try to find what fits them, what they like, you know, what's at their pace, what's inclusive, you know, and it may just take some, you know, some shopping around, but it's having those social opportunities are so important. As I mentioned, kind of working on building social skills, you know, try to figure out kind of what's the sticking point for them, like what is it that makes it hard for them, and, you know, try to find opportunities to fill in some of those gaps. There are kind of training programs and curriculums that are out there, you know, and so, you know, finding a, you know, a psychologist or an occupational therapist or somebody who, you know, who offers some of these programs could be helpful. But even just like practicing at home, like figuring out kind of what's hard for them, like what are they struggling with, and maybe having that conversation of like, you know, how are you feeling? Like, are you feeling lonely? Do you wish you had more friends? Like, what makes it hard to have friends? You know, and help them to identify, you know, those pieces. And you may have just observed them in social situations and have a sense for, you know, what are the sticking points for them? You know, do they need help with navigating, you know, certain social situations, with just starting a conversation? Do they maybe need to practice some icebreakers or, you know, ways of kind of more naturally engaging in conversations, or, you know, knowing what to share and what not to share, or, you know, things like that. You know, use visual supports for social rules, kind of helping them to understand like what are those kind of hidden social rules that can be really confusing. Like, when do we talk about this and we don't talk about that? Like at work we talk about these things, you know, with close friends and family we talk about these things, but we don't talk about these things at work. You know, those sorts of things can be really, you know, can impact their friendships. And so have some of those conversations at home. You know, again, addressing, you know, their kind of mental health needs, you know, kind of be on the lookout for, you know, you know, are they withdrawing more and more from social relationships? You know, is it having a negative impact on their life? Are you seeing other changes in their sleep or appetite, changes in anxiety or irritability, you know, and seek professional help. So people with, you know, with Down syndrome, with intellectual disabilities, with mosaic Down syndrome, benefit from therapy, from talk therapy. And I think too often these aren't offered to them, you know, and it can be hard to find a therapist who, is comfortable, you know, and knowledgeable working with people with, you know, neurodivergence. It's getting better, you know, and again, I think, you know, the kind of, you know, autism world has kind of, you know, has kind of led the way in a lot of ways. There's a lot more kind of neurodiversity affirming therapists. And so I think if you search for that, I mean, I think especially for people with mosaic Down syndrome, that certainly fits within, and that they may not understand it. They may, I think people who advertise themselves as being, inclusive, or neurodiverse affirming, most of their experiences is with autism. But I think there still are enough parallels there that can translate, that can translate well. I think they're at least a little bit more open-minded, a little bit more curious, kind of understand that people, are coming with, maybe a wider variety of, of skills and challenges than somebody from the general population. The next one is kind of strengthening family connections. And so, being that source of support for them, can be helpful, but also so that they just feel, they feel supported by someone, and they feel like they can come and talk to you and kind of open the door, open those conversations about loneliness, kind of ask them like, who are your friends? Like, do you wish you had more friends? Like, what do you think would be helpful to you? And so the more that they feel like you're a safe place to come and have those conversations with, the more that you can help them, kind of problem solve. Think about, are there opportunities to strengthen connections with, with siblings? Maybe a sibling has moved away and that is, has been very stressful for them, and so maybe setting up more regular Zoom calls, with that sibling, or, activities like that can be helpful. All right, so some other things to be concerned about, and this is not loneliness specific, but just kind of mental health specific, of things to keep an eye out for, when to be concerned. Are you seeing social withdrawal? Is that changing? Are they not wanting to spend time with their friends anymore? Are they not wanting to engage in the hobbies and activities that they usually engaged in? Are you seeing an increase in physical complaints? Kind of more headaches, more stomach aches. Those could be a sign of underlying, kind of mental health concerns. It changes in their appetite. Are they suddenly eating more? Are they suddenly eating less? Either of those can be a sign of a lot of things. Mood changes, and that could be being persistently sad, being irritable or angry, or just a flat mood, where they're just not responding to, to things in the usual way. Like, they're not getting sad about things, they're not getting happy about things, they're not getting angry about things. Like, that's also a sign that, that something may be going on. Sleep changes, when we see like regression, like the Down syndrome regression, a lot of times the sleep changes we see, that can be one of the early signs where we're starting to, and it's not just regression. Sleep changes are associated with some other things too. But when we start seeing that kind of like a day-night reversal, where they're starting to be up all night and then sleeping all day, that's concerning. And again, that kind of expressing, loneliness. Okay, so some things to, where to go for help. Look into, your local Down Syndrome Association, of course, IMDSA. The Special Olympics does a lot of great work, and I like the Special Olympics because it's, they're more about just inclusion. So it's not necessarily like you can come and participate and volunteer, and maybe they don't want to be a Special Olympics athlete, but maybe they're interested in volunteering and helping Special Olympics athletes. They think there's a lot of, opportunities too for them to be a mentor, and so maybe they don't have an intellectual disability. Maybe they don't feel like they're, they have a disability, but it could be a way that they could support others, and we get a big mental health boost from supporting others. Check around to see. I mean, psychologists specializing in IDD are really rare, but you might have one in your area and not know about it. But otherwise, finding a mental health professional who is open, and willing to learn. But for pretty much all of these mental health disorders, cognitive behavioral therapy is the first line treatment, and really should be offered to everybody, regardless of whether or not they have, a few extra chromosomes. All right, so key takeaways: loneliness is really common, but there's a lot of things that we can do to help support people with mosaic Down syndrome who are experiencing loneliness. Things like creating social opportunities and connections, building social skills, addressing those mental health concerns, You know, using technology, getting online, social media can be helpful. I think it's important to have conversations about the drawbacks, you know, of being online too much, or, you know, some of the risks that come along with social media usage. But it can certainly be helpful, I think, especially for people with mosaic Down syndrome, you know, who have a harder time finding, you know, finding people like them, who've experienced what they've experienced. And so, let's see. So I just wanted to highlight a few resources. So on the IMDSA website, we have this Blues Busters workbook, which is meant to be just kind of a CBT based, you know, workbook to kind of teach some of the basic concepts of cognitive behavioral therapy, learning how to identify thoughts, how to change behaviors to feel better. I also worked with the National Down Syndrome Society to create, this is a guide that's really designed for mental health care providers, so that they can kind of understand the needs of people with Down syndrome and how they can make some changes to their practices in order to be more inclusive. But it's my hope that it can be the sort of thing that can also help parents, you know, kind of as they're looking for providers. If the provider says like, well, you know, I'd like to help, but I don't really have a whole lot of experience with, you know, with mosaic Down syndrome or Down syndrome, that this could be a resource. You could say like, oh, here's this resource, here's this guide that has some tips, you know, and maybe they'll feel a little bit more open. There's some other great resources. I think, you know, I mean, I think there's a lot of things. I think every person with mosaic Down syndrome is different. And so I think that, you know, we can learn a lot, you know, from the resources and things that have been developed for people with Down syndrome. And just think about, okay, like some of these things might apply, but some of them may apply. And so I think, you know, kind of having those, you know, just having, okay, this works for people with Down syndrome. Maybe this will work for my loved one with mosaic Down syndrome is worth a try. And this is the study that I mentioned we're going to be launching. It is hopefully going to be available March, April or so. We'll send an email out through the IMDSA, you know, maybe newsletter, or just, you know, I'll kind of reach out to Brandy once we're ready to start actively recruiting. But we're developing a screening tool for Down syndrome regression disorder, so that we can do a better job of identifying it and getting people the care that they need. And so we're going to be recruiting, you know, like a pretty big sample of people with Down syndrome. And so we want people with mosaic Down syndrome to participate, because we want to be able to know, you know, be able to hopefully, you know, get some information about, you know, how many people are we seeing with mosaic Down syndrome who have regression? Does it look different in people with mosaic Down syndrome versus without? So we really hope that people with mosaic Down syndrome will sign up for this study, so we can maybe answer some of those questions too. And so for this study, we're looking for people with or without regression. So we want to actually get people who don't have regression, because we want to know, you know, what, you know, like what do these symptoms kind of look like? Are they, you know, you know, like how often do we see individual symptoms in people who don't have regression? So we want a wide range of people. All right, I will, let me skip ahead. The next webinar is coming up. That's going to be Sunday, March 29th, on language, literacy, and executive functioning in mosaic Down syndrome. That's Dr. Susan Lovell and Emma Conradi. So definitely check that out. But I'll put this back up if you want to check out our website, and my contact information is there. So if I don't get a chance to answer everybody's questions, please feel free to email me. We had a few people that submitted some questions ahead of time, and I tried to address, where did they go? I lost it. I tried to, you know, kind of work in as many as I could. Let's see, some of the questions. So somebody asked a question about antidepressants. I'm not a psychiatrist, so I cannot comment on, you know, on kind of dosage or antidepressants, because that's not my specialty. I would say, from what I have, you know, just kind of like generally heard, the kind of rule of thumb, you know, amongst people who have, you know, maybe kind of an identified genetic difference, is the rule of thumb to, like, you know, psychiatrists who, you know, who work specifically with people with developmental disabilities usually say start low and go slow. And so they recommend, because it's a little bit of an unknown, how that genetic difference impacts the way that their bodies metabolize certain like medications, that they recommend, that psychiatrists or, doctors kind of start with a lower dose than they might otherwise use, and titrate it up much more gradually. Give like if they might go up 1 milligram, every week, that they go up half a milligram every week. That they just use a much slower, slower process. And so, yeah, because we don't really know how Down syndrome, affects that. And there are some some studies that are kind of ongoing. I know there's some that are looking at like some ADHD medications to try to understand, do people with Down syndrome kind of metabolize these drugs differently, but we really don't know yet. I hope I answered the question about kind of selective mutism and social anxiety. That was one of the questions, but we definitely do see selective mutism in people with Down syndrome and mosaic Down syndrome too. Finding somebody who treats social anxiety, I think is where I would say reach out to, find a psychologist who has experience with selective mutism or social anxiety, and that's a good place to start. Usually if you treat it from a social anxiety kind of perspective, you just usually have to go much slower in terms of getting them to speak. That you're starting off with like trying to get them to just, kind of whisper, or trying to get them to just, and you're just moving into like very, very small incremental steps. There was a question about kind of processing speed and word retrieval challenges. I tried to touch a little bit on that. We do see that kind of working memory is a kind of a relative weakness in people with Down syndrome. And I do think that I think that is a big part of how I think that kind of processing speed fits into a lot of the social anxiety, as I mentioned. Yeah, and some of those things from I think the question also asked about, let's see, are there things that kind of, cause processing time to get slower as they get older? I think certainly, for folks that are entering into their 50s and 60s, with like Alzheimer's, we see a slowing there. We don't have good data yet on like otherwise of kind of across the lifespan. The ABCDS study is a large study where they're doing MRIs and trying to understand healthy brain development in people with Down syndrome. And I think they're starting to expand more into adolescence and trying to get a bigger picture. Like we get these little snapshots of like there's these studies in little kids with Down syndrome, and there are just fewer and fewer studies. And then we have studies of people who are aging with with Alzheimer's and Down syndrome, but we're missing a lot of the picture as far as like what does brain development look like across the lifespan. So we don't really have good data on that yet, unfortunately. So other questions?
So Ruth, Yvonne has asked if you could maybe go, I think she's talking about 5 slides back. It was on what to do to help them. If you can just pull that up. I told her.
Yeah. And I'm happy to, send these slides out too.
Yeah, and I told her that we would
maybe this one.
Would it be helpful to have a person? Oh, hold on 1 second. So Levon, is this the one creating social opportunities? You can just do a thumbs up.
Or unmute, can we unmute her?
She's not on I have to go back in and find her.
Okay.
I've got the chat up. She said no. I did tell her this would be recorded and it would be on our YouTube channel so she can go back and find it.
Okay.
There is 2 other questions real quick that I wanted to bring up. What are the rates of suicide in the Down syndrome population? Do we know of any?
We don't know. It's not been systematically studied. I've gotten that question a lot. I think there are some studies that, just of people with intellectual disabilities, and there are some studies of people with autism that suggest that it's higher. We see, kind of other self-injury kinds of things too, and sometimes it's harder to tell, depending on the person's, kind of communications ability to know whether or not it's kind of suicidal self-injury or non-suicidal self-injury. But I have not seen any studies specifically looking at suicide, but it certainly is possible. And I would say, if you see, if they're expressing things that make you concerned about suicide, reach out and and get help, because you don't want to risk missing that potential.
I will say in the years that I've been working with IMDSA, I have not met anyone that has, committed suicide that had Mosaic or have heard of it. So I feel like that's a positive thing. So I have another question, Ruth, and it said, would it be helpful to have a person diagnosed with DSRD for your study who does not have Mosaic? I'm guessing.
Yes,
Yeah.
yes, absolutely. Please, please, yeah, sign up. Yeah, so for this study, we're just looking for anybody who has any form of Down syndrome to participate in this study. So probably most of the people that will participate will have non-mosaic Down syndrome, but we just want to make sure that we don't end up with only non-mosaic Down syndrome. Like we want, we're hoping to, to get enough people who have mosaic Down syndrome that we can, kind of do a little sub-analysis or whatever, kind of take a little deep dive into mosaic. So the study is not specific to mosaic Down syndrome, but it is inclusive of people with mosaic Down syndrome.
And then one other question was, are there any medications that help with anxiety, OCD, or depression for our kids?
I'm not a psychiatrist, so I can't provide kind of medication advice, but I do know that doctors do prescribe, kind of, antidepressants, and, often will try the same medications that they might prescribe for these conditions, in the neurotypical population, for people with Down syndrome, and again, with that rule of thumb that I've heard, just, to start low and go slow. But yeah, but I can't really comment on any specifics, since I'm not a psychiatrist. It's out of my scope of practice.
Well, thank you. Quick, this is more of just a statement. Just says, I have to leave the meeting, but I have found this webinar very informative and helpful, and some of great takeaways, which I can take action now. Thank you, Ruth. I live in Victoria, Australia. So that was pretty neat to have somebody joining us today from Australia.
That's awesome.
I will definitely participate in other webinars and the forthcoming survey. My daughter, Jessie, is 20 with MDS. So we're glad that you were able to help that family. So that's great. And then the last question that we'll take right now, because like I said, we were trying to do a hard stop at 5. So we'll take this last question. It says, regarding the DSRD, can an abrupt change in personality, including aggression, be a symptom of this? Also, can an illness like the flu cause this change? Also, what is the treatment for DSRD? Oh.
Yeah, great question. So so sometimes it is described as just like a drastic change, kind of in personality, and so that could be it. So not necessarily isn't necessarily DSRD. It could be a lot of things, but that could be a symptom of DSRD. And then yes, like an illness like the flu. So our kind of leading theories right now, we don't really know what causes DSRD. The leading theories is that it is some sort of kind of neuroinflammatory kind of, like process that's happening in the brain, kind of inflammation in the brain, basically. And it seems like from what we can tell, it can be triggered by an illness, like you said, like the flu, some sort of a, COVID, kind of other illnesses, by like medical, getting like intense medical interventions, like, surgeries or things like that. So, something that kind of causes the body to kind of have some sort of an inflammatory reaction, or stressful life experiences. And that's the other thing that seems to be common, is that somebody goes through some kind of major life stressor. Not necessarily, I mean, it can be traumatic, but sometimes, it's just, it's another, the loss of a loved one, a sibling moving away, they've gone through some major life stressor, and, and stress does cause our bodies to, react, cause an immune system reaction that can lead to systemic inflammation in some people, we don't fully understand, again, like when is that a problem, and why is some people and not others. But yeah, so it could be, it could, the flu could cause it. And the treatments right now, so the kind of leading treatments are the same treatments that we use for catatonia often. And so the things that, that are published are things like benzodiazepines, like kind of high dose benzodiazepines, electroconvulsive therapies. And then there's a clinical trial ongoing right now looking at immunomodulating therapy, so IVIG. So it requires infusions and things like that, to get, as well as JAK inhibitors. These are the things that they're testing. So we don't know yet if those are effective, but there are definitely some promising results. And so there is, I don't know if they're still enrolling, they might still be enrolling people in the clinical trial at the Linda Cernick Institute and at Children's Hospital Los Angeles with John Santoro, somebody put in the list there, are the people who are running that trial. But those are, so there are, so that, there are treatments for it. It's just a matter of kind of getting the right diagnosis and ruling out other potential medical causes too. So sometimes it can be something else, but.
Great. Well, thank you so much, Ruth. We appreciate you taking the time out of your day today and being here with all of our families. And like I'm sure as you read into the notes and here in the chat box, that everybody is very appreciative of the information that you provided to us today. Like she said real quick, we do have another webinar coming up. It's March 29th, which is on a Sunday at 4 p.m. And that's on our reading and executive functioning with those with mosaic Down syndrome. They just got done wrapping up their study. So we'll kind of get some of the little bit of the results, preliminary results. At this time, I think we're going to go ahead and conclude our webinar and then give us about a week or two. And then we hope to have this up, the recording up live on the IMDSA YouTube page. So once we get it up there, we'll send out an email and everything just to let you guys know it's up on the recording and stuff too. So thank you guys again so much for joining us today. We appreciate you.
Great. Thank you so much for having me.
Thank you. Bye-bye.
Bye.